Well, again, again, thank you for the kind introduction, and would really like to thank the meeting organizers for the invitation to present as part of this really wonderful education symposium series. So it's truly my honor. So thank you very much. All right. So regarding objectives today, I'll first provide a brief background about traumatic brain injury, or TBI, and pathophysiology of injury. Then I'll review the evidence regarding utility of various imaging techniques for evaluating TBI, and provide data that radiologists can use to advise their clinical colleagues regarding appropriate imaging for patients with TBI via evidence-based clinical imaging protocols and recommendations. And finally, I'll briefly talk about so-called advanced neuroimaging methods related to, in this case, specifically related to repetitive sports-related TBI, and work that I'm conducting in my lab using these advanced neuroimaging methods to study repetitive sports-related head impact exposure. All right, so first let's go into a brief background of traumatic brain injury, kind of focused on background, but also pathophysiology and role of imaging. So as many of you know, TBI results in significant mortality and morbidity, with approximately 300,000 hospitalizations and many deaths each year in our country. And of course, the leading causes of TBI are things like falls and motor vehicle accidents, assaults, and one of my interests, which is sports-related injury. And for those who survive, the long-term sequela can range from mild cognitive impairments to really severe disability. The economic burden, at least in our country, is quite high, which I believe is also true around the globe. So lots of dollars spent on traumatic brain injury. Beyond the economic burden, I think the thing that's interesting for physicians is that those who survive, TBI is thought to be a gateway to a variety of conditions and neurodegenerative diseases about which not much is known, like Alzheimer's, Parkinson's, other psychiatric diseases, headache, epilepsy, etc. So what happens to the brain with a traumatic brain injury? And this is a movie from our Wake Forest finite element brain model, produced in collaboration with my biomedical engineering colleague, Dr. Joel Stitzel and his group. And it incorporates MRI data and just shows the deformations associated with a real world, in this case, a subconcussive head impact. And you can imagine the amount of deformation that you might see with an even greater head impact. And so for those who are familiar with white matter tractography and the white matter tracts of the brain, we've been working together to extend our finite element model to include white matter tracts. And this movie might play. Let's see if, oh, sorry, hold on, let me go back. Here we go. Let's see if it plays. Oh, I think I have to play them individually. Let's see. So it's supposed to show how the white matter tracks. Oh, I'm sorry, I can't. It's not going to play. But basically, just shows a very similar movie of all the white matter tracks as they kind of oscillate and change in the brain due to a head impact exposure. So what's happening to the brain pathophysiologically when it's being deformed by all this force that's propagated through these tissues, particularly with respect to brain structure and function? Well, it affects all of the intracranial substructures like blood vessels and axons, and in particular can result in a continuum of disruption of brain white matter with a whole host of subsequent secondary processes triggered by the initial injury, like microglial activation and inflammation. So, what's the role of medical imaging in TBI? So let's transition now to review the evidence regarding utility of various imaging techniques for evaluating TBI. So several of my colleagues and I published a series of white papers a few years ago describing the use of conventional imaging and so-called advanced imaging in the setting of TBI. And specifically, these data were carefully reviewed for the quality of the evidence using the Oxford Center for Evidence-Based Medicine levels of evidence, which range from level 1A systematic reviews, being the highest quality of evidence, to somewhat more subjective level 4 consensus statements and expert opinion. And I've included these details for reference in case this presentation is recorded, and I'll report the levels of evidence for the data that I discuss. And the level of evidence was used to generate more objective evidence-based recommendations ranging from class 1, that is conditions for which there is evidence for or at least general agreement that a procedure or treatment is beneficial, useful, and effective, all the way to class 3, conditions for which there is evidence or general agreement that a procedure or treatment is not useful or effective, and in some cases may be harmful. So those are the classification numbers there. So due to time constraints, I'll confine myself to reviewing conventional neuroimaging techniques for acute TBI, specifically moderate to severe, but also mild TBI. I'll also briefly discuss what the American College of Radiology, the ACR Head Injury Institute, has been doing with these data with regard to developing a new RADS. You know, if you've ever heard of the BI-RADS, LI-RADS, but in this context, for head trauma, it'll be TBI RADS. So let's discuss what we know about diagnostic imaging in the context of moderate to severe TBI. And I think we all know that non-contrast CT is sensitive and specific for identifying intracranial hemorrhage, extraaxial fluid collections, skull fractures, radiopaque foreign bodies like shrapnel, as well as for detecting cerebral edema, swelling, and signs of herniation. And all of this is borne out by strong level 1B evidence in the literature. But beyond simply identifying intracranial abnormalities, there's evidence that non-contrast CT is sensitive for identifying intracranial injuries resulting in death and or requiring some kind of neurosurgical or neurologic intervention, intubation for greater than 24 hours, or admission for 2 days. And there are numerous non-contrast CT clinical algorithms to predict clinical outcomes associated with moderate to severe TBI, which incorporate non-contrast CT findings as a major factor. Some of these include ones like the Marshall CT classification, Rotterdam CT score, Helsinki CT score, and the Stockholm CT score. The Marshall score has a few important limitations, like dealing with multiple injury types, and that it's not a linear score, which can make it a bit difficult to use as a scale for severity. The Rotterdam score was modified from the Marshall score, and it's based only on the combination of non-contrast CT findings like presence of subarachnoid or intraventricular hemorrhage, effacement of basilar cisterns, midline shift of greater than 5 millimeters, presence of subdural hemorrhage, and absence of epidural hemorrhage. And this score aims to predict 6-month mortality based on these findings and has been well standardized and validated to do this. Now, MRI, magnetic resonance imaging, is not currently indicated as a primary diagnostic imaging modality for acute TBI, and part of this is because of the complexity of scanning these patients emergently. That being said, I think we'll all agree that it's common practice to acquire, in a lot of cases, maybe a brain MRI when the results of a non-contrast head CT are normal and there are persistent unexplained neurologic findings after a TBI, and this is a class 1 recommendation. And as you know, typical pulse sequences used for TBI include conventional T1 and T2 weighted sequences, as well as T2 flare, diffusion weighted imaging, gradient, and susceptibility weighted MRI. And there is a literature comparing MRI and CT to study where MRI might be able to outperform CT in terms of identifying evidence of trauma. So, for example, it's been demonstrated that MRI can be more sensitive than CT for detecting epidural and subdural hematomas, particularly. I think what they really mean is very, very small ones, non-hemorrhagic cortical contusions, brainstem injuries, because there's a lot of streak artifact on CT through the brainstem, and particularly for the detection of hemorrhagic and non-hemorrhagic so-called diffuse axonal injuries in the white matter, and this is level 1B evidence. Several studies have demonstrated that T2 and FLAIR sequences can be more sensitive than CT for detecting subacute subarachnoid hemorrhage, so small subdural hematomas, brain contusions, and brainstem injuries, and that's evidence level 1B and 2. You can see those tiny, tiny amounts of blood product, and in this case, you can sort of see it a little bit better. This is the same patient, non-contrast CT on the left, T2 FLAIR on the right. You can sort of see that the blood in the interpendicular fossa is a little bit more conspicuous on the MRI. T2 star gradient sequences have been demonstrated to be grossly similar to CT for detecting acute intracranial hemorrhage, and you can see the arrow there showing a blood CSF level in the occipital horn, atria and occipital horn of the right lateral ventricle. You can't see much of that in the left lateral ventricle, but on the T2 star susceptibility weighted gradient image, you can sort of see right there where the arrows, the blood products are just much, much more conspicuous. And that's with T2 star gradient. New susceptibility weighted images with quantitative susceptibility mapping, which really haven't been scrutinized to this level, are also available and have some unique characteristics for evaluating intracranial injury, like being able to determine if something is a calcification versus blood, but has not been as rigorously studied as T2 star because gradient, because that's been around for a lot longer. But T2 star gradient imaging can be much better than CT for identifying subacute and chronic hemorrhage, which also is 1B and 2 level of evidence, and you can sort of see that playing out here in the cerebellum. I mean, you can sort of see injury in the cerebellum and the cerebellar peduncles there, but a lot more conspicuous on that gradient image. I think we all know that diffusion-weighted imaging is sensitive to acute parenchymal contusions, as well as axonal injuries and fat emboli not seen on CT and other MRI sequences. And diffusion-weighted imaging is also important to evaluate secondary brain ischemia related to herniation and vascular injury, which is level 2 evidence. And you can see all of these little bright fat emboli that are scattered throughout the brain, particularly at gray-white junctions. I think it goes without saying that there's no scientific evidence that gadolinium-based intravenous contrast agents are indicated for conventional MRI in the setting of TBI, which is a class 2B recommendation. There have, however, been a few studies showing that intraparenchymal contusions can enhance during subacute stages, which is thought to be due to blood-brain barrier disruption and inflammation. So let's move on to mild TBI, although typically non-contrast head CT is normally something that we get in the majority of patients with mild TBI. It nonetheless is the imaging choice because it can certainly detect surgical brain abnormalities, even if they are rare in the setting of mild TBI, and thus a class 1 recommendation. But even though non-contrast head CT is widely available and good at detecting intracranial trauma, it does result in radiation exposure and additional cost. So the real question for mild TBI is, which patients can safely forego a non-contrast head CT? So in summary, for acute, moderate to severe TBI, non-contrast CT is the first line of imaging in the acute phase and can predict mortality and unfavorable outcomes in these patients, and that's a class 1 recommendation. MRI may be indicated in acute TBI when results of non-contrast CT are normal and there are persistent unexplained neurologic findings. That's also a class 1 recommendation. And MRI, more specifically T2 star gradient and susceptibility weighted imaging, is very sensitive to microhemorrhages within the brain. However, whether the number and volume of these microhemorrhages are associated with injury severity or outcomes remains inconclusive. So that's a class 2A recommendation. So let's move on to talk about some criteria that radiologists can use to advise their clinical colleagues regarding appropriate imaging for patients with TBI via evidence-based clinical imaging protocols. So there are 3 well-known prospectively validated criteria: the Canadian CT head rule, the New Orleans criteria, and the National Emergency X Radiography Utilization Study 2 criteria. Now, it should be noted that these criteria are weighted toward high sensitivity for identifying patients with clinically important CT findings rather than reducing the number of exams performed. These criteria indicate a head CT for patients with mild TBI and any one of the following. Glasgow Coma score less than 15, suspected open or depressed skull fracture, signs of basilar skull fracture, 2 or more episodes of vomiting, 65 years or older, amnesia for events occurring more than 30 minutes prior to impact, and then, of course, dangerous mechanism. CT is obviously also indicated for patients with neurologic deficit seizure, presence of bleeding, diathesis, and anticoagulation use. The New Orleans criteria is used for patients with GCS of 15 and indicates that a head CT is warranted if the patient complains of headache and/or vomiting, with additional criteria including age of greater than 60 years, drug or alcohol intoxication, persistent anterograde amnesia, seizure, or visible trauma above the clavicle. With Nexus 2 criteria, CT is warranted if there is skull fracture, scalp hematoma, neurologic deficit, altered level of alertness, so GCS less than 14, abnormal behavior, coagulopathy, or persistent vomiting. And these criteria were applied prospectively in a multi-center investigation that enrolled more than 7,000 patients, and sensitivities relating to clinical outcomes were highest for the New Orleans criteria, which you can see in the middle column, NOC, New Orleans criteria. Now, in contrast to sensitivity, specificity for these criteria has been found to be pretty low in numerous studies, which makes sense given that these are screening tools, and the New Orleans criteria has been found to have the lowest sensitivity, less than 25%. Although MRI is regarded as more sensitive than CT, particularly for tiny amounts of blood, most symptomatic patients with mild TBI really have no abnormalities on conventional MRI. There are really no studies to date have demonstrated a significant clinical change associated with early MRI for acute mild TBI, which is level 2 evidence, but MRI may be indicated for mild TBI if there are persistent unexplained neurologic symptoms and when the non-contrast head CT is normal. And this is a class 1 recommendation. In so-called complicated acute mild TBI, MRI has been shown to be more sensitive for detecting blood products that are occult or not seen on CT, including all stages of subarachnoid hemorrhage, extraaxial collections of blood products, contusions, and axonal injuries. One study called the Transforming Research and Clinical Knowledge in Traumatic Brain Injury has reported that 27% of patients with mild TBI have MRI abnormalities even when head CT is normal. So in summary, for acute mild TBI, non-contrast CT remains the imaging of choice in the acute phase. Non-contrast head CT has a high negative predictive value for excluding the need for neurosurgical intervention in patients with mild TBI. That's class 1 recommendation. And we have several of these criteria that all three major prediction rules that identify patients with mild TBI who can safely avoid non-contrast head CT, and each one of them has different sensitivities and specificities, with New Orleans criteria having the most sensitivity. That's class 1 recommendation. Despite the higher sensitivity of MRI for detecting axonal injury among patients with mild TBI, the routine use of brain MRI for detection of injury in the setting of acute mild TBI is not really supported at this time, and that's a class 2 recommendation. So we've talked a bit about the evidence and imaging recommendations for acute TBI, but this can only take us so far. So what we still need are standardized traumatic brain injury management plans that take into account the imaging evidence and use these data in a quantitative or semi-quantitative way to standardize terminology, that we use in our imaging reports, and thus direct or guide patient management. And so the ACR Head Injury Institute has been working on developing the Traumatic Brain Injury Reporting and Data System, or TBI RADS. And I'm serving as co-chair for TBI RADS along with my colleagues Shumat Nyogi and John Tesouris from Weill Cornell, in support from Laura Coombs and others from and other Head Injury Institute members. So the goal of TBI RADS is to work towards standardizing management paradigms with unified data-driven treatment and management algorithms that will improve patient outcomes, decrease healthcare expenditures, and provide an informatics database to stimulate discovery and innovation for TBI. We hope it will also provide a system for education and training and an interface with technology like AI technology to streamline and standardize reporting. Of course, it's a work in progress, but this is a draft created by my Weill Cornell colleagues, and you'll see some similarities with other American College of Radiology RADS paradigms, like BI-RADS for the breast tissue, and LI-RADS for liver, and TI-RADS for thyroid. And I'll very briefly take you through it. So TBI RADS category 0 refers to the need for additional imaging. So could be in the setting of suboptimal imaging, could be non-specific or inconclusive findings that require further imaging workup. So, if you saw something hyper dense on CT and you're not sure if it's calcium or blood, or, maybe you want to work it out with another imaging modality. So that would be category 0. TBI RADS category 1 relates to when you have a normal CT scan. So we have a category 1A, that's a completely normal CT scan with the thought that we could we could discharge the patient home, probably without really any additional follow-up if the patient's neurologically stable and seems normal. Category 1B is a normal CT scan, but yet there's some unexplained neurological deficits and findings for which there could be some use for a neurology consult, and maybe consideration of an MRI, and maybe consideration of admission to the hospital if needed. So TBI category 2 relates to benign and incidental findings. So that aren't, and I should say, not related to the TBI. So you could potentially consider discharge with clinical follow-up versus admission. So category 2A would be benign findings, in which case you could discharge if neurologically stable and normal without follow-up. Like I'm trying to think of something, something like a asymptomatic, very, very small Chiari malformation, or something that might not need, or like tonsillar hyperplasia or something like that. Category 2B, non-emergent incidental findings, where there might need to be a neurology or neurosurgical consult, where you could discharge with neurological and/or outpatient imaging follow-up, and that could be for some like tiny little incidentally noted meningioma or something. Category 2C, urgent incidental findings, so either unexplained neurologic deficits where you might need a neurology or neurosurgery consult admission for inpatient workup. You'd have to determine whether you need ICU or a non-ICU monitored bed, and you could consider an MRI if the patient is stable. So with TBI category 3, that's related to findings that are mild on the severity scale. So, minor traumatic subarachnoid hemorrhage, subdural less than 5 millimeters with no midline shift or herniation. You might neurology consult followed by discharge versus admission. Category 3A, if they're neurologically stable, that'd be potentially a discharge with neurology outpatient follow-up or outpatient follow-up imaging. Category 3B would be if there is a neurological deficit where you'd want to consider admission to non-ICU monitored bed or potentially consider an MRI if the patient is stable enough to get one. So then TBI RADS category 4 relates to findings that are considered moderate on the severity scale. And so this would be moderate traumatic subarachnoid hemorrhage, small contusions, minor intraventricular hemorrhage, extraaxial hematoma like a subdural or epidural that's greater than 5 millimeters with maybe less than 5 millimeters of shift, but no mass effect like basilar or cisternal effacement. And for those, you're going to want a neurology or neurosurgery consult. You're going to want to admit them, but perhaps to a non-ICU monitored bed, and you could, again, consider an MRI if they're stable enough to get one. And then finally, we have category 5, which relates to findings that are considered to be severe. And so that's greater than 5 millimeters of shift, of midline shift, basilar cisternal effacement, large hemorrhagic contusions, dissection, infarction, diffuse brain edema. And so you're going to want a neurology or neurosurgical consultation admitted to an ICU monitored bed and potentially MRI if you're stable. And you can see, a lot of those findings on these two head CTs right here. So, let's talk about advanced imaging and maybe, number one, how that relates to all of what we just talked about, but also could introduce you to how I'm using advanced imaging to study at least sports-related traumatic brain injury. So, regarding advanced neuroimaging techniques for TBI, like diffusion tensor imaging, kurtosis imaging, multi-shell diffusion, resting state bold spectroscopy, positron emission tomography, magnetoencephalography. To date, there's really insufficient evidence supporting routine clinical use of these advanced neuroimaging methods for diagnosis and or prognostication of traumatic brain injury at the individual patient level, and that's a class 2B recommendation. However, there is a lot of data in the literature, and these methods are widely used in research. So again, now I just want to switch gears and talk about how I'm using these imaging methods to study sports-related TBI, and in particular, repetitive head impact exposure that might not lead to a concussion. So regarding sports specifically, there are about 2 to 4 million sports and recreational related concussions each year, and this is particularly common in youth sports, with about 9% of all high school athletes reporting concussions, and of those reported, about 47 occur during American football. And here's a more complete list of the biggest offenders with respect to specific sports, and it differs a little for boys and girls. And as I mentioned, football is by far the biggest offender for boys, followed by hockey and lacrosse, whereas for girls, soccer dominates, followed by lacrosse, field hockey, basketball, and even cheerleading, which isn't shown on this slide, and that's for the U.S. And so, of course, sports-related TBI has become a hot topic in the media and in popular culture, and has its own movie with Will Smith there. But this is not a new phenomenon, and some of the earliest work regarding sports-related TBI was conducted around the turn of the century and focused primarily on boxers. So this paper was published in Journal of the American Medical Association by Martland and Newark back in 1928. So, we've known for a long time that concussions and sports-related head impact exposure can lead to brain injury. The schematic diagram down here on the bottom right depicts proposed mechanisms of injury involving blood products, here in perivascular and perineuronal spaces of boxers who experienced multiple concussions, which is supported by this axial pathologic specimen to the right, demonstrating multiple punctate hemorrhagic foci in white matter regions, particularly the frontal lobes and corpus striatum that seem to track along perivascular spaces. What's great about this is actually a pathologic slice of the brain. You would think it's a CT, but it's a brain slice. It's a real brain slice. Very interesting. And today, this is referred to as chronic traumatic encephalopathy, or CTE, which is thought to be a neurodegenerative condition that's received a lot of press among professional NFL American football players. You can see this is that slice referred to as punch drunk, from boxers in 1928. Here's you can relate that, although, sorry, this is an axial image compared to coronal, but you can sort of still see the similarities in the volume loss and, some of the staining compared to, a normal brain. And it's known, chronic traumatic encephalopathy is known to involve a number of specific brain regions important for things like emotional regulation, decision-making, memory, and other critical functions, as well as associated with a variety of neurodegenerative diseases, which are issues that are arising among career NFL American professional football players. And, this is what we hear about all the time on the news. But we feel like this, and the critical theme of our work is that, these professional American football players, that's just the tip of the iceberg. So there are only about 2,000 professional football players, whereas there's maybe 100,000 collegiate players and more than 5 million youth and high school players. And what we've learned is that most professional football players, the 2,000, were also college players, they were also high school players, and they were also youth football players. So perhaps chronic traumatic encephalopathy is really just the final sequela of a lifetime of repetitive head impact exposure. So the issue I'm most interested in goes beyond concussion or TBI and is really focused on total exposure, with concussion and all the cumulative subconcussive hits resulting in total exposure. And what's really interesting for children is that there are guidelines for limitations for mercury exposure, lead exposure, all kinds of exposures, but not really any limitations for head impact exposure. So I don't know if this is going to play. So this is, let's see. Oh, no, it's not going to play. Anyway, it just shows two youth football players. This one standing here, and this young one standing here, and they basically run at each other at full speed and just hit each other in the head with their helmets. And we're really interested in that. It doesn't necessarily lead to a concussion, but some of these children can experience 1,000 of those impacts over a season of practice and play, and this is again taking place during a time of extraordinary brain development for these children. And I think it's safe to say that there's broad consensus that head impacts producing concussions or traumatic brain injuries are bad for the brain, and particularly very bad for the developing brain. But what about all the head impacts that don't lead to any overt signs or diagnosis of concussion? Should we be concerned about all these potentially thousands of subconcussive head impacts? And this idea of lifetime cumulative exposure, particularly during times of critical brain development, is fundamental question in our research team is asking, and also the fundamental question of some close colleagues that I have in Bangkok, Thailand. I think some of them might be on the phone, but they're doing really important work that's very similar in the domain of kickboxing. So I hope you guys are out there, because I'm a big fan of your work and really enjoy collaborating with your team. And so very briefly, whoops, let's see if this is going to work. Okay, there we go. So just wanted to switch gears and talk about sports-related head impact exposure as a model to begin to understand the effects of TBI in general, and a way to validate our advanced imaging methods, the one that we talked about. And that's when you combine biomechanics of the head impact exposure with sensors, along with cognitive testing and then imaging. And those three combined really allow you to do something that's really unique. And it gives you the opportunity to quantify the exposure in a way that can't be done with more naturalistic studies of TBI, because we have the advantage of quantification in terms of the timing, the exact timing of the injury, the magnitude, or I should say the exposure, the timing of the exposure, magnitude of the exposure, and the location of each of the head impacts. And this allows us to explore traumatic brain injury like a pharmacologic study, where we can evaluate dose response and the time course of effects in a way that can help us break new ground in understanding the pathophysiology of this injury. Whoops. And this is part of a multi-year IRB-approved study funded by NINDS that we call ITACL, in which we're measuring head impact biomechanics as well as pre- and post-season cognitive testing and neuroimaging. And basically, we're measuring all head impact exposures across all games and practices using helmet sensors. And all of these data are recorded in real time during every practice and game using the system here. And we video record all games and practices to confirm each hit. Of course, we are now transitioning over to our mouthpiece-based sensor designed by Dr. Stitzel and his team that really tightly couples to the maxilla and has better kinematics to allow us to measure head impacts, particularly in non-helmeted sports. And we've collaborated with our friends at Stanford and spent a lot of time validating our mouthpiece sensor and conducting field testing. And we're deploying these in girls soccer. It seems to work pretty well, and they wear it pretty readily. And we can use epidemiologic methods to express each player's risk-weighted cumulative head impact exposure to look for dose-response relationships with our imaging and cognitive measures. And so let's briefly talk about resting state BOLD as a way to understand how subconcussive head impact exposure affects brain networks. And first, we can talk about the default mode network, which is the most studied network in the resting state, and is derived from observations that specific brain regions are more active when the brain is in a wakeful resting state than during performance of external tasks. And we evaluated resting state network connectivity associated with subconcussive head impact exposure from 22 of our male football players. They were age 8 to 13 years old. None of them had a history of concussion prior to or during the football season. So first, we identified the default mode network in our players, as well as several task-positive networks, including executive function salience and dorsal attention networks using group-independent component analysis. We found statistically significant preseason versus postseason changes in network connectivity in players with the greatest exposure versus those with the least exposure. Specifically, we saw an increase in default mode network interconnectivity with the salience network between pre- and postseason scans. And we also saw that the magnitude of antiphase correlation between default mode network and right executive network decreased significantly in postseason scans. And there was no significant difference in connectivity between default mode network and dorsal attention network or left executive network. But what's a little surprising is that these findings are similar to those seen in patients with concussion or mild TBI, although none of these patients had concussions. And we also have data showing that these network changes correlate with cognition measures of processing speed. We have also used machine learning approaches with resting state BOLD measures of interhemispheric connectivity as our imaging feature of interest. And the aim of this study was to classify non-concussed football players as having high versus low cumulative head impact exposure over a single season of football. And we used a generalization of the support vector machine recursive feature elimination. And so we were able to achieve classification accuracy of about 92%. And the regions with interhemispheric connectivity that were most discriminative for classifying high and low cumulative head impact exposure were the cerebellum, hippocampus, portions of the frontal lobe, putamen, and the thalamus. With regard to other functional techniques, we measured cerebral blood flow using ASL, arterial spin labeling, acquired during pre and postseason MRI, from which we computed blood flow change metric. This allowed us to look for associations between change in cerebral blood flow and cumulative head impact exposure. So gray matter segmentation was obtained using VBM8 processing, and regions of interest were obtained by applying our AAL atlas to arterial spin labeling cerebral blood flow data. And we focused on regions that have been associated with pathologic changes of chronic traumatic encephalopathy. And we hypothesized that these regions may be particularly sensitive to head impact exposure and began to manifest head impact related functional changes early in life after perhaps one season of play. And as such, we chose regions of interest from AAL associated with CTE, like frontal lobe, areas of frontal lobe, temporal lobe, basal ganglia, and cerebellum. And regression analyses demonstrated statistically significant inverse linear relationships between head impact exposure and pre versus postseason cerebral blood flow, such that higher head impact exposure was associated with postseason decreases of approximately 5 to 10% in blood flow in these regions. So perhaps this reflects very early changes in brain function after a single season of play, even in the absence of concussion. So let's move on to other common advanced imaging methods to study the brain in the setting of TBI, and that's advanced diffusion imaging techniques such as DTI and tractography. Oops, let me go back. And oops, cannot play. I was going to show you all the white matter tracks in one of our football players, but we've been using fiber propagation tracking to extract the whole length of white matter structures and reconstruct them into three-dimensional images using diffusion metrics. So these are tracks we constructed from one of our football subjects in our iTackle study. And so we published one study in radiology in which we looked at the white matter tracks of 32 players and computed DTI metrics, mainly just looking at simple ones like fractional anisotropy, FA, and mean diffusivity. But we also looked at linear, planar, and spherical subcomponents. For this analysis, we looked at the largest white matter tract, which is the corpus callosum. But we also looked at some other ones, the inferior fronto-occipital fasciculus shown in blue, the inferior longitudinal fasciculus shown in yellow. And what we saw in the corpus callosum were statistically significant linear relationships between the change in fractional anisotropy over the season, so preseason versus postseason, and compared to our risk-weighted cumulative measure of exposure. So basically, fractional anisotropy FA decreased between pre and postseason as head impact exposure increased. And this was also true for the inferior fronto-occipital fasciculus, as well as, and it's interesting because it connects portions of frontal, occipital, and temporal lobes. And of course, we're concerned about ultimate downstream effects and function of those regions. I also wondered if these changes would be more pronounced at the gray-white junction, where material properties change and where we see injuries clinically after high velocity impacts, like so-called diffuse axonal injuries, right there. And in fact, we did find statistically significant linear relationships between FA over the season and cumulative exposure, and these were more pronounced at the gray-white junction sort of region than in the body of the tract, which we think is interesting and kind of parallels what we see clinically. We also wondered if there are relationships between brain microstructure and cognitive function, and in fact, we did see some changes that were associated with task performance, specifically processing speed. So task performance was not abnormal per se, but players with greater change in white matter required more time to achieve relatively normal performance, which can be an early marker of injury. We are also using neurite orientation, dispersion, and density imaging, NODI, and I know my colleagues in Bangkok are also using NODI. And so we recruited several football players, instrumented them, collected their biomechanical head impact exposure, and looked at MRI data before and after the season using track-based spatial statistics using NODI parameters for measuring fiber orientation, dispersion, and neurite density. And we found some statistically significant linear relationships between the cumulative exposure, cumulative head impact exposure, and fiber orientation dispersion index. So more exposure was associated with diminished values for ODI, orientation dispersion index, so less directional complexity in large tracks, including the inferior frontal occipital fasciculus, inferior longitudinal fasciculus, and unsedate fasciculus, but no association between cumulative head impact exposure and neurite density on the number of fibers, which we think is really interesting because it really suggests a possible signature for these cumulative non-concussive head impacts, and perhaps it reflects some exposure-associated deformation in white matter tracks without a gross decrease in fiber number. Running out of time, but we'll just briefly mention magnetoencephalography, which is another imaging tool that measures the magnetic fields of the brain. And here's our fully automated MEG processing pipeline. You can see MRI here, MEG here. It kind of looks like a hair dryer. Here's one of our football players. And we can, and again, the brain is electrochemical, and every electrical impulse generates a magnetic field that we can detect with our MEG. It produces this cloud of data that we can then beamform into the brain to determine where the signal came from. And we've published that you can use these data just like you use resting state bold to identify things like default mode network in this case. But I'm not going to talk about network connectivity, rather delta waves. So what are delta waves? They're the lowest frequency waveform associated with sleep. There's not very many there's not much delta activity present during wakefulness in normal subjects. But as the next slide says, we do see more abnormal delta wave activity in abnormal brains, like ones that have Alzheimer's disease, schizophrenia. It's very well known and talked about, associated with traumatic brain injury. And so potentially can be used as a biomarker for brain injury and potentially a clinical tool to diagnose subtle changes of TBI. And we know that in the normal setting, delta wave activity decreases with increasing age. So if it goes up, it's moving in the wrong direction. And we've done some very simple studies looking at the vector of forces from our biomechanics and relating those to delta wave low frequency waveforms. And what we've seen is, well, the more impacts you have, the more abnormal delta wave activity you have. So here's 239 impacts compared to greater than 800 impacts. You can see more delta wave activity with more impacts. You can also see that what looks like a coup counter coup type effect, where our participants who are hit in the front of the head, here's a sagittal view of brain, if they're hit in the front of the head, they have more abnormal delta in occipital. And if they get hit on the top of the head, they have more abnormal delta wave in inferior frontal. So location matters, and sort of it follows what we would expect. We've also done some longitudinal studies in our football players. So here's preseason delta wave activity. And this is kind of a normal pattern, what you would expect, that delta wave activity is going down over time. So after the season, it's even further down. 9 months after, it's even further decreased. Not so much in other parts of the brain. So that was parietal lobe. In occipital lobe, it looked like after the season, delta activity went up, but it looks like there was some recovery after about 9 months after the season. Same with temporal lobe. But what's concerning is in frontal lobes, it goes up after a season of American football and continues to go up even after 9 months. So almost like participants are on a new developmental trajectory with abnormal increases in delta wave activity. So that's a lot to go over, but in conclusion, I would say that number one, just to kind of go over what we talked about with acute, moderate, and severe TBI, basically evidence supports the use of CT as a first line for imaging, with MRI reserved really for persistent symptoms. You can see obviously that CT works pretty well. For acute mild TBI, CT again remains the choice for for injury in the acute phase and has high negative predictive value for excluding interventions. And there are certainly lots of guidelines to help us determine when it's when it's safe to avoid getting a CT, and that again, MRI does have a role, but perhaps for those with maybe persistent symptoms. There, alas, is not really a role for advanced neuroimaging that I just talked about for clinical purposes, but certainly is used in the research domain. But we'll have to do a lot more work to be able to apply some of these advanced neuroimaging techniques to individual patients and have them provide meaningful data about care of our patients. However, we can use them in the research setting, and what we're learning is that cumulative sports-related head impact exposure may affect the developing brain, and this is important to study so we can learn about how to mitigate the risks and optimize the benefits of sports activity for children. And with that, I thank you very much for your attention, and we'll be happy to take any kinds of questions that you might have.
Thank you very much, Dr. Whitlow. It was a very interesting and comprehensive talk. So we'll have...
Oops.
Yeah. For acute mild TBI, as you said, non-contrast CT is the first line. But for pediatric patients who are stable, can MRI be taken as maybe the first line?
Potentially, I think so. I mean, one of the issues with MRI is accessibility. So often, at least in our healthcare system, we don't often have MRI availability in the emergency department, and also the other challenge with MRI is motion. So getting children to lay still. So I think there's an age range, like let's say 5-year-old children, 6, 7, where you can talk to them and keep them still in an MRI and do a really quick MRI scan. One could really consider that. But in maybe a 1 or 2-year-old, it would be so hard to get them to stay still. And for MRI in that setting, we often have to use general anesthesia. So you'd have to weigh what are the risks of radiation exposure versus general anesthesia. And so probably in that setting, we're still stuck with probably stuck with CT.
Thank you. Do we have any more questions?
Hey, Dr. Whitlow, this is JP. Can I ask you one quick question? First of all, thank you so much for such a wonderful lecture. I really appreciate it. Very comprehensive. Just wanted to know, are there any artificial intelligence to detect TBI? Do we have? So I just wanted to know your thoughts and experience on that.
Yes, I have a whole talk on artificial intelligence for detecting traumatic brain injury that I'm happy to give another time if people are interested. But yes, there's a lot of work in this domain for artificial intelligence for detecting TBI. Mainly, a lot of it, the early work was really focused on detecting blood products. So there's lots and lots of algorithms and they're frankly not very difficult to develop. We had one of our senior research associates, Ryan Godwin, in our lab here, who won, I believe it's like second place for an algorithm for detecting blood products at American Society of Functional Neuroradiology a couple of years ago. But there's also many commercial vendors now who provide AI software platforms for detecting blood products. There's Icometric, AI Doc, and many others for doing that. And then so that's interesting, AI for detecting blood products. But HI, human intelligence, is pretty good at detecting blood products in the brain. So a lot of times you don't really need the AI because HI can do it really well. But what HI can't do, what human intelligence can't do, is really predict outcomes. So for example, let's say you have someone with mild TBI. They have a normal head CT. They have a normal brain MRI. Well, most people with mild TBI, even if they have symptoms from that, they recover. But there's a small percentage, 5-10%, who will go on to have chronic long-term problems like headaches or other symptoms. But we have no way of determining who is going to recover and who is not going to recover because all their brain imaging looks normal. So that's one area, the area of predictive analytics, where AI could probably do things that HI is not going to be able to do, which is to take what otherwise looks like a normal imaging study and then determine if someone is going to have symptoms long term or if they're going to recover completely. And if you can identify someone that's going to have symptoms, if you can identify them early, it gives you a longer window of opportunity to intervene and try to make them better. So lots of work on AI. Happy to give that talk sometime if there's interest.
Thank you so much.
A question from the chat. They would like to ask for pediatric trauma in children, what kind of sedation do you use? Is chloral hydrate usable in that situation?
We are very fortunate here that we have pediatric anesthesiologists who manage our anesthesia. I would say that I don't know that we're using chlorohydrate. I could, but if there's interest, I have a very close colleague, Dr. Doug Ryrie, who's a pediatric anesthesiologist and a physician scientist, and there's lots of work going on in this domain about anesthetics, and there's also, just like I was talking about head impact exposure and how that affects the brain, there's lots and lots of emerging data that anesthetic exposure can also affect the developing brain. And so there are recommendations that are starting to emerge about best practices for anesthesia, particularly for young children. It's a fascinating topic. I wish I knew more about it, but could certainly connect you with one of our pediatric anesthesiologists who could talk in detail about that. But the other thing that we're thinking about, and I see my colleague Josh Tan on the phone, we're thinking about maybe starting to use virtual reality and 3D goggles that we can put on children, and we can transport them into an immersive virtual reality environment where they feel less anxious about being in a hospital setting, because we can transport them anywhere. They could be in their home. We could, so that when they look around, it looks like home. We could transport them to the beach. We could transport them to wherever they feel most comfortable, and perhaps, or maybe even design games for kids where the game is keeping really, really still. And maybe in that way, if we could distract children, maybe we could use less anesthesia. So we're really thinking about that and hoping that maybe we could use distraction with virtual reality as a way to decrease our reliance on anesthesia.
So that actually sounds very fascinating and something to go in depth with. So in that case, I think we have come to the end of our questions asked so far. So I would like to thank you so much, Dr. Whitlow, for such a wonderful talk. And thank you for sparing your time to join us this weekend.
It was such an honor. It was such an honor for me. Thank you so much, and happy to come back anytime. What a great event, and really thanks to the organizers for putting this together, for putting the series together. It's very, very innovative, and it's been just one of the biggest honors for me to be a part of this. So thank you very much.
So I think our coordinators will certainly keep that in mind. We would all like to thank you, and we'll end the session here. Thank you very much, and have a great weekend ahead.
Thank you. You too.